Welcome to the Deep Dive. We're here to make complex topics, well, much clearer.
That's the plan.
And today, our focus is super sharp, Ewing's sarcoma. If the MSRA is coming up for you, this is basically your high-yield guide.
Exactly. We want you to have a really solid grasp of this condition.
Yeah, our mission is pretty simple.
Yeah.
Pull out all the must-know info, from what it is, right through to how it's managed, help you revise effectively, save you some time.
Let's do it. So first off, what actually is Ewing's sarcoma?
Good starting point.
It's a primary malignant bone tumor. So it starts in the bone and it's cancerous. We typically see it in children and young adults.
Okay. And where does it come from?
Well, interestingly, it originates from these primitive neuroectodermal cells, very early stage cells, part of the developing nervous system, essentially.
Right. And location.
It commonly affects the long bones like the femur, but also the pelvis and the chest wall.
And the key features.
Under the microscope, you see these characteristic small, round, blue cells. And importantly, it has a high potential to spread. Metastasize.
Okay, so bone cancer, young people, likes to spread. Got it.
Yeah.
What actually get the ball rolling? What's the cause behind it?
Yeah, the exact trigger isn't fully known. But we do know a key factor involves genetics, specific changes called chromosomal translocations.
Translocation?
Think of it like bits of chromosomes swapping places, specifically between the EwSR1 gene and genes from the ETS family. The most common partner is FLI1.
And this swap creates?
It creates a sort of hybrid protein, a chimeric fusion protein. And this new protein basically acts like a faulty on switch, drives uncontrolled cell growth, leads to the tumor.
A genetic misfire, creating a rogue protein.
Okay.
Are there specific things that increase someone's risk?
It's interesting, actually. Clear risk factors are, quite rare. Most cases just seem to happen sporadically. But there are some potential links, things like previous radiation exposure, maybe some rare genetic conditions like Li-Fraumeni syndrome. And we do see it slightly more often in Caucasians.
But mostly out of the blue.
For the most part, yes. No obvious identifiable cause.
Okay. So going back to that EwSR1 ETS fusion that's central to the pathophysiology, how the cancer develops, right?
Absolutely. That abnormal fusion protein essentially hijacks the cell's normal growth signals.
How so?
It just overrides the normal controls that tell cells when to grow, when to divide, when to stop. This leads to that rapid, unchecked cell growth that forms the tumor itself. The precise downstream effects are still being actively researched, though.
Right. So let's say you see something suspicious on an X-ray. How do you tell Ewing's apart from other things, the differential diagnosis? Any memory tips here?
Definitely. For differentials, think ROT in the bone.
ROT in the bone. Okay.
R as for other radiological findings, meaning other bone tumors like osteosarcoma or maybe osteoblastoma. O is for other tissues. Sometimes soft tissue sarcomas can look similar initially.
Right.
And T is for tumors from elsewhere. So metastatic disease like neuroblastoma that's spread to the bone, you absolutely need imaging, but also a biopsy for histology and, crucially, identifying that gene fusion for a definitive diagnosis.
ROT in the bone. That's useful.
Okay,
who typically gets this? What's the epidemiology look like?
Well, Ewing's sarcoma is pretty rare overall, certainly in the UK. It mainly affects children and adolescents. The peak age is really the second decade of life, so teenagers mostly.
And gender.
Slightly more common in males than females.
Got it. So if a teenager presents, what symptoms should make you think of this, the clinical features? Got another memory aid for us?
Yes, let's use pain and FAT.
Pain and FAT.
P is for pain. That's usually the main thing.
Yeah.
Localized bone pain, often quite persistent, maybe worse at night.
A key symptom.
Definitely. A is for appearance. You might notice swelling or even feel a lump or mass at the site.
Yeah.
I is for injury. Sometimes the first sign is actually a fracture through the weakened bone, a pathological fracture.
Wow.
And N stands for nonspecific symptoms, which links to the FAT part. Fatigue, unexplained weight loss, or anorexia, and maybe a low-grade temperature, a fever.
Pain and FAT. Easy to remember. So if those signs point towards Ewing's, what investigations are needed?
Right, the workup. It usually starts with imaging, plain x-rays first, then often CT scans and especially MRI to get a really detailed look at the tumor size and how far it extends.
And then the confirmation.
The crucial step is the biopsy. That confirms it's cancer, shows those small, round blue cells, and allows for the genetic testing to find that EwSR1 ETS fusion.
And checking for spread.
Exactly. You'll do further tests, blood tests, bone scans, maybe PE scans, imaging of the chest to see if it's metastasized.
Okay, diagnosis confirmed. How do we manage it? Is there a mnemonic for treatment?
Yep, for management, think NCSR, like no cancer spreads around rapidly.
Okay, walk us through it.
N is for neoadjuvant chemotherapy. Chemo given before surgery to shrink the tumor down.
Makes sense.
C is more chemotherapy, but this is usually after surgery adjuvant chemo to mop up any remaining cells.
Got it.
S is for surgery. The goal is to remove the tumor completely, ideally limb-sparing surgery, but sometimes amputation might be needed.
Okay.
A stands for alternative local treatment. This is often radiation therapy, used either instead of or alongside surgery.
Right.
And ours reminds us that the specific regimen is refined or tailored based on the tumor's location, size, whether it's spread, and how it responds.
NCSR. Neoadjuvant chemo, surgery, alternative local, refined approach.
Good. What about the outlook, the prognosis?
Prognosis really depends on a few things. The stage of diagnosis is key.
Yeah.
Has it spread? Also, how well the tumor responds to the initial chemotherapy, and of course, whether metastasis is present.
Have things improved? Definitely. Survival rates are much better now with modern, intensive, multimodal treatment. But outcomes can still vary a lot. Long-term follow-up is absolutely essential because of the risk of recurrence and also potential late effects from the treatment itself. Generally, localized disease does better than metastatic.
Understandable. And finally, what are the potential bumps in the road? Complications.
Well, you worry about local recurrence, the tumor coming back where it started. Metastasis is a big one, usually to the lungs or other bones. Depending on where the tumor was and the surgery needed, there can be functional impairment. And of course, chemotherapy has its own side effects, bone marrow suppression, risk of infections, potential long-term organ toxicity.
Okay, that covers a lot. This has been a really focused, high-yield run-through of Ewing's sarcoma. Should be really helpful for anyone revising for the MSRA.
I hope so. We've hit the main points definition, causes, features, management, and hopefully those memory aids, ROT in the bone, pain, and FAT, and NCSR will help make it stick.
Yeah, definitely useful. You know, thinking about that EWSR1 ETS fusion being so central, it really makes you wonder, doesn't it? What kind of future targeted therapies might we see? Things that directly go after that specific genetic problem.
That's the big question, isn't it? Something to watch.
Absolutely. Well, for more revision resources, don't forget to check out pathophysiology.com and also freemsra.com. Thanks for joining us for this deep dive.